Good morning, everybody. Welcome to Phoenix Children's Grand Rounds. Happy Tuesday morning. We're having a little bit of technical difficulties here in the Cohen Center, so bear with us. I think we've got it straightened out now. We've got a special presentation this morning. We have three presenters from three different specialties who will present on multisystem inflammatory syndrome in children, temporally associated with COVID-19. I'm going to introduce the speakers in the order that they're going to present this morning, but before I do that, I want to remind everybody of a couple things. One, we'll reserve a few minutes at the end for Q&A with our speaker panel. So please, you have either the chat function or the Q&A function that you can put your questions into. The chat usually works very well, and we'll be able to read the questions at the end for our presenters. Second is that tracking CME is super easy for anybody here at Phoenix Children's or anybody else watching the video today that wants CME credit. We'll give you a text, a 5-digit code to text to the U of A CME number. We'll put that in about 10 minutes. And then if you haven't done so, there's a one-time registration on the U of A CME website where you can very easily track your CME in print reports for yourself. So I encourage you to do that one-time registration if you haven't done so. It just takes a couple minutes. All right, without further ado, I'm going to introduce Dr. Wasim Ballan first. Dr. Ballan completed his Pediatric Infectious Disease Fellowship at the University of California, San Francisco, and he serves here at Phoenix Children's as the Medical Director of the Antimicrobial Stewardship Program. Since it was established in 2017, it is also the Associate Medical Director of Infection Prevention and Control here at Phoenix Children's. Our second speaker is Dr. Michelle Monquitz. Dr. Munkwitz completed her pediatric residency at U of A in Tucson. She then completed a critical care fellowship in Salt Lake City and currently serves as a pediatric intensivist at Phoenix Children's, where she is also the Assistant Program Director of the Critical Care Fellowship and is the Chair of the Ethics Committee at Phoenix Children's. Last but not least, this morning is Dr. Kaleo, who is a pediatric rheumatologist here at Phoenix Children's. He completed a combined internal medicine and pediatrics residency program at Phoenix Children's and also served as a fourth-year chief resident. He then completed his fellowship in pediatric rheumatology at the University of California, Los Angeles. Dr. Ballan will get us started today. Dr. Ballan, take it away.
All right, good morning, everyone. Thanks, Michael, for the introduction. And what we're going to be talking about today is one of the hot topics of the pandemic. And keep in mind that this is a disease that is less than a year old, basically, and there's still a lot to learn about it. So myself, Dr. Munkwitz, and Dr. Eid have been working on this as kind of a special task force at PCH since we started seeing patients to help develop the guidance in evaluation and management of those patients. So what we're going to try to cover today is put the link between MISC and SARS-CoV-2, then go through the case definition that the CDC wants us to use to diagnose those patients, then go into the epidemiology, talk a little bit about the pathogenesis or what we know so far about MISC and how it's potentially or kind of looks similarly to toxic shock syndrome and Kawasaki disease, and then we'll go over the PCH guidance that we've developed for the evaluation and management of those patients. And then Dr. Munkwitz will focus on the critical care of those patients since a lot of them need ICU care. And then Dr. Eid will focus on the special treatments that we're using and the follow-up and outcomes of those patients. So, again, I mean, this is a new disease. The first reports of this disease came out from the UK, and it was in March of 2020 when they noticed that there are a group of kids who are coming in with this hyperinflammatory state. So their presentation is basically that of a fever, sore throat, headache, abdominal pain. Some of them needed ICU care because they had shock and organ dysfunction. And there was evidence of inflammation based on their labs, and they kind of uniformly had lymphopenia and elevated D dimers. The majority of those patients actually tested negative for SARS-CoV-2, but there was the epidemiologic link was based on the fact that most of those patients were seen after they saw their surge of acute COVID-19 cases. So between March and April of 2020, they had 38 cases described in the UK, And that's when the Royal College of Pediatrics and Child Health came up with the guidance, and they called the disease Pediatric Multisystem Inflammatory Syndrome, temporarily associated with COVID-19, or PIMS, basically, or PMIS. Right after that is when the US started seeing the surge of acute COVID-19 cases, and immediately following this, specifically in New York State, is when we started seeing a similar presentation of some of the kids. And that's when the CDC came out with the health alert in May of 2020. And the name that the CDC decided to go with was Multisystem Inflammatory Syndrome in children, or MISC, associated with COVID-19. And that's basically the terminology that we're using here in the US. And with that, the CDC actually came up with the case definition to try to kind of sort out which patients fit that presentation or not. So typically, there are patients that are less than 21 years of age with 2 or more system involvement with inflammatory process. So, and that could be their cardiac system, renal system, respiratory, hematologic, gastrointestinal. We're going to go a little bit into the details of the presentation of each one of those systems in a second. And then they need to have an epidemiologic link to SARS-CoV-2. And that's usually in the form of a positive PCR or antigen, or a positive serology. So they have the antibody for COVID-19, or they are known to have had an exposure to someone who was diagnosed with acute COVID-19 within the 4 weeks prior to the onset of symptoms. One of the important parts of that case definition is that there should be no alternative plausible diagnosis that would basically explain the presentation. At the beginning, last spring, when we started seeing those patients, we were getting a lot of calls, appropriately so, about patients presenting with fevers, and because there's, obviously there was still a lot of concern, there wasn't a lot of, a lot of people were not familiar with the disease. We were getting a lot of calls about, kids coming in with fevers and whether this was MISC or not. Some of those kids had simply UTIs or some other infections that would explain their presentation. And this is why we always try to focus. If you have a plausible diagnosis that would explain the presentation, you should not, immediately jump to the diagnosis of MISC. Now, when we're talking about the temporal association between acute COVID-19 and MISC, that's based on, the different cities that saw, surges of acute COVID-19, including Phoenix. So, for example, in Phoenix, we had the first surge in July of 2020, and immediately after that, we had an influx of patients coming in with MISC, and then kind of tapered down, and then we went up through a second surge in January of this year, and now we're seeing a lot of patients coming in with MISC. So what is noticed, and this graph shows, what happened in New York State, basically, where you can see the yellow line is the cases of acute COVID-19, or I'm sorry, the percentage of people who tested positive for SARS-CoV-2, and the brown, blocks are basically what the cases of MISC that were reported after that. Now, in terms of how widespread this disease is, this is a map of the US. This is from the CDC website that shows the different states that have reported the disease. If you look at Arizona, we're in the, we're obviously in the dark blue section, and that, puts us at one of the highest states that have reported the disease. The CDC does not share an exact number of cases per state, and that applies also to the Department of Health here in Arizona. They don't share how many total numbers of cases have been reported. So basically what we know is that we've reported more than 51 patients so far from the state of Arizona. And when you look at the total numbers that have been reported to the CDC, there are now more than 2,000 patients who fit the case definition. And out of those, there were 30 deaths. The CDC is updating those numbers on a monthly basis. So this number is from last week's update. Now, when we start digging into the epidemiology of the disease and start looking at what are the characteristics of the patients who are coming in with this presentation, what we're noticing is that it's more prevalent in the Hispanic and Latino population and also in the Black population, and less so in the Asian population. Now, if you keep that in mind, remember, for example, in Kawasaki disease, This is a disease that is more prevalent in Asians compared to other ethnicities. So that, kind of starts showing you the difference between MISC and Kawasaki. The other thing is the age distribution of those patients. So even though the definition, includes anyone who's less than 21 presenting with hyperinflammatory syndrome, the majority of patients are between the age of 1 and 14, and it seems like the average is around 8 years of age. That's also higher than the typical age for Kawasaki disease. Sorry, the slides keep advancing on their own, but anyway. So that also is higher than the typical age group that we see with Kawasaki disease. Most of the Kawasaki patients that we see are between the age of 1 and 4. So you can also see that's another difference between MISC and Kawasaki. Now, in terms of the presenting symptoms, so there's a lot of overlap with what we see with toxic shock and MISC. So basically, if you remember, with Kawasaki disease, the clinical criteria includes, conjunctivitis, rash, lymphadenopathy, stomatitis, extremity swelling and erythema, with skin changes eventually including the skin peeling. So all of those can be seen with MISC. But on top of that, we're seeing more other systems that are involved, and more commonly so compared to Kawasaki disease. For example, neurological symptoms, are something that we've seen in a lot of kids who presented with MISC, and also the cardiac involvement in this MISC seems to be similar to myocarditis rather than just simply the coronary artery changes that we see with MISC, and that's what's causing those patients to go into shock and needing ICU care. We have a study with the CDC, and so far it looks like around 40% of patients that are coming in with MISC are needing ICU care during their hospitalization, whether they're directly admitted to the ICU or transferred to the ICU from a pediatric floor. There's also more lung involvement with MISC, and then on the blood tests, basically, the striking thing is this thrombocytopenia and lymphopenia, which are not things that we typically see with Kawasaki disease. So that's another difference also between those two diseases. And the renal involvement is presenting as hyponatremia or AKI. And then I left the GI tract till the end because that seems to be the most common system to be involved. So we're seeing, most kids coming in with abdominal pain, nausea, vomiting, and sometimes some elevation in their ALT and AST. So when we start looking at the different systems that are involved in the presentation of MISC, again, the GI system seems to be the most commonly involved. So more than 90% of patients are having some symptoms related to the GI tract. It's not present on this graph, and Dr. Munkwitz is going to go into the details of the cardiac system, but the cardiac system involvement is around 80% of those patients. And Dr. Munkwitz is going to talk about the different types of presentations that are related to the cardiac system involvement. A lot of patients are also showing up with hematologic involvement. So that's in the form of, as we said, the lymphopenia, thrombocytopenia, coagulopathy. And then, as you see, there are some, the rest of the systems, are, common, but less so compared to the GI tract, the hematologic system, and the cardiac system. So in summary, basically most cases were in children, as we said, between the age of 1 and 14 with an average of 8 years. More than 70% of the patients are in patients who are Hispanic or Black. And 99% of patients had a lab link to MISC, but only 1% were the ones around the patients with COVID-19. And most of the presentations were 2 to 4 weeks after acute COVID-19, but we've definitely seen patients who presented 6 to 8 weeks after their acute COVID-19 infection, but the majority are still within that 4-week window. The one thing that I want to focus on, and obviously we don't have the exact statistics for this because we're still collecting the data, is that this is still a very rare complication of acute COVID-19. The big numbers that we've seen is simply because the virus was very prevalent in the community. When I was looking at the math in terms of how many cases were reported to the CDC and how many pediatric patients have been reported to have tested positive for SARS-CoV-2, obviously this doesn't give the full picture, but it ends up being around 1 in 10,000 patients, pediatric patients who test positive for acute COVID-19 are going to develop MISC. So again, this is a rare complication. We're not sure yet about the exact, rate of, that reaction, but it seems to be in that order, and one per 10,000 patients. So when we start thinking about the immunology of this presentation and why are those patients presenting with that and what are the predisposing factors, there's actually still a lot to learn about this, but there are some speculations in terms of what's triggering the immune system to cause this response. So obviously, we start with the infection. So that's, the infection of the respiratory tract. A lot of kids don't even have the symptoms of the pulmonary infection, or they're mildly symptomatic. And for some reason, it is thought now that there might be a superantigen phenomenon from the virus that causes macrophage activation, triggers the T cells to go into to release cytokines and cause a cytokine storm, and at the same time, the B cells and the plasma cells producing the antibodies, and the combination is causing this hyperimmune response. There's definitely a genetic predisposition, or at least we think that there's a genetic predisposition, and that partly explains why, it's more prevalent in certain ethnic groups. And again, I mean, that's still a speculation. There's still more work, looking at this. There are some other reports that are looking at the interferon response as a cause of this reaction. So what we know so far is that the patient who had an early interferon response, so they peaked their interferon early on in the infection, had a more rapid viral clearance and less inflammation. So those are the patients who had mild disease. The ones who had delayed interferon response had a slower viral clearance and more inflammation, and that, is leading to severe disease, including MISC. Again, those are still based on small, studies. We're still waiting for more information about this. Now, as I mentioned at the beginning, it sounds like, there's definitely, an overlap between the MISC, toxic shock, and Kawasaki disease. And if you start looking into the details of those diseases, there's actually more overlap with toxic shock compared to Kawasaki disease. And that's simply when you start looking at the different systems that are involved. So for example, with the myocardial dysfunction seems to be similar in MISC and toxic shock. So there's more myocarditis type of phenomenon compared to Kawasaki disease. Now there's a subset of Kawasaki disease that is called, Kawasaki disease shock syndrome, or we call it sometimes Kawashaki, that can involve, carditis, but again, I mean, this is a very small percentage of the patients presenting with Kawasaki disease. Then when you look at the coronary artery changes in MISC, toxic shock, and Kawasaki disease, in MISC and toxic shock, we do see sometimes transient dilation, but we don't typically see the aneurysms developing eventually, unlike Kawasaki disease, where obviously a percentage of those patients end up with aneurysms. Again, when you look at the hematologic, presentation of those patients, again, lymphopenia and thrombocytopenia are both seen with MISC and toxic shock, but not typically in Kawasaki disease. So to summarize, since obviously Kawasaki disease is more commonly seen in pediatrics than toxic shock, so there's always this comparison between MISC and Kawasaki disease. Again, what we know is that the hyperinflammation in both, diseases seems to be different or triggered differently. So it seems like the T cells discriminate between Kawasaki and MISC. There's a speculation that IL-17A is the driver for Kawasaki, but not MISC and hyperinflammation. And there seems to be an autoantibody candidates that are looked at in MISC that are probably part of the trigger of this hyperimmune response. So again, to kind of summarize the comparison between MISC and Kawasaki disease, MISC happens in older kids compared to Kawasaki. It's more common in African, Afro-Caribbean, and Hispanic patients compared to Kawasaki disease that happens more in patients of Asian descent. There's more GI neurological system involvement in MISC, and more shock and myocardial dysfunction compared to Kawasaki, where it's more typically an arteritis. MISC patients present with lymphopenia and thrombocytopenia, which is not something that we typically see with Kawasaki disease. Now, what are we doing in terms of, how are we evaluating and managing those patients? So the American College of Rheumatology put out the guidance in July of 2020, and they published it officially in December of 2020. Here at PCH, when we start seeing those patients, and obviously because there was still some confusion about, how we evaluate those patients and how to proceed with their management, we came up with a guidance that is partly based on the ACR guidance. And that basically is mostly to guide the initial evaluation of those patients. And we are going to be in the process of developing a clinical pathway for the inpatients now that we've had, almost a year of, information on how to do things with those patients. So we're going to be developing a clinical pathways for those patients after they get admitted to the hospital. But on the initial evaluation of those patients, obviously we're looking at whether they have a fever and whether they have at least 2 clinical features suggestive of involvement. And if that's the case, then we want the providers to send what we're calling the tier 1 labs. And those are basically basic labs to check for signs of inflammation. So that includes the CBC, CMP, CRP, ESR, and testing for SARS-CoV-2 with the PCR and the antibody test. And if we see that on those labs, we're seeing, a hyperinflammatory signs, which, is basically a high CRP, ESR, and lymphopenia, thrombocytopenia, hyponatremia, neutrophilia, or hypoalbuminemia, that's when we want to go into the tier 2 labs, which are more detailed labs looking at different systems. So that goes into, checking the troponin, the proBNP, the coagulation studies, some more specific, cytokines like IL-6, and we also are testing those patients for COX-E, IgM, and IgG, and quantiferon. And the reason we included those 2 tests in the evaluation is because some of those patients we were speculating may need treatment with biologics, and wanted to make sure that they're screened before we give them any biologics that would cause a prolonged immunosuppression. We haven't had to use this a lot on patients, and that might change with time, but we just wanted to be on the safe side and make sure that we're not missing any patients who might have a latent infection with any of those 2 infections. And so basically, if the tier 1 labs are abnormal, we want the practitioners to call both ID and rheumatology from the beginning, so that we're guiding the rest of the management and the evaluation from the time of admission to the hospital, and also involve the cardiology division if there's any cardiac involvement on the initial presentation. We also developed a dashboard with the help of Dr. Vaidya. So we do have a COVID-19 dashboard at PCH that tracks all the patients who are testing positive for COVID-19. But we also, part of that dashboard, we developed an MISC tab where we're keeping track of all the patients that we've treated so far. And once we report them to the Department of Health, they get included in this tab, so we're able to figure out how many patients we've seen so far, what type of management they've had. And on this tab, we've actually included also the patients who were suspected to have MISC and were treated as if they had MISC, but didn't fit the case definition, and that's basically because they didn't have the epidemiologic link. Keep in mind that some cities actually managed a lot of patients with MISC or for MISC, even though they didn't have the epidemiologic link. And that was happening when there was a lot of community spread of the virus. So even though we're not able to pinpoint a specific exposure, the assumption that they might have had an exposure that they were not aware of. And with that, I'll pass it on now to Dr. Munkwitz, who's going to talk about the critical care of those patients.
Good morning, everyone. So almost a year ago now, when COVID-19 was just starting to pick up speed and things were changing rapidly, the Open Pediatrics, which is an open access global peer-reviewed platform, which was created and run by Boston Children's Hospital and Harvard Medical School, created this world shared practice forum. And this was a place where the critical care community could get together on a regular basis, starting out bi-weekly, and then as things stabilized a little bit less frequently, where we could share our experience and our opinions on treatment as things were changing so quickly. So all about oxygen delivery and critical care, where we monitor and support organ function in a multidisciplinary team approach. So I'd like to tell you about a case, a patient that we admitted last fall, and this was an 11-year-old that we admitted. He was an obese young man. He had a history of aortic coarctation, which was repaired when he was young. He presented with 2 days of fever, dizziness, vomiting. He had a rash on his palms and the dorsum of his feet, and he had bilateral conjunctivitis and headache. When he presented to the ED, he was febrile and tachycardic and tachypnic, and did have good blood pressure. You can go ahead and advance. And here just shows his physical exam. Most notably, he was ill appearing but not toxic. He was noted to have the conjunctivitis. He was tachycardic. He still had his murmur. And he did have this rash that we could see, as well as some mild swelling to his hands and feet. So the ED has seen this before. And so they inserted an IV, got a blood culture and labs drawn, gave 1 fluid bolus, some antibiotics, and admitted to the hospital service, as he was non-toxic appearing, and although tachycardic, only required a 1 fluid bolus. So you can see his labs here. He was found to be hyponatremic, thrombocytopenic, and leukopenic, with some evidence of inflammation, also showing some mild kidney injury and liver injury. So when he went to the floor, initially he did okay, was tachycardic into the 130s, continued to have a fever, but then somewhere around midnight started to look a little bit worse, and over the course of the night received 3 additional fluid boluses, remained febrile, tachycardic, and tachypnic. Some additional labs were drawn, and he was found to have his BNP, which was originally in the 400s, went up to 1800, and with that, along with his tachypnea and tachycardia, he was transferred to the PICU. So in the PICU, he was febrile. He was then tachycardic to the 140s, although when he defervesced, it went back down to the 130s, which is where he had been. His exam had changed a little bit in that he had some discomfort, some intermittent chest pain, and some edema associated with pain. Although he was alert and playful and up in the chair watching TV and playing games. EKG was done, which showed no change from before that we had for him. An echocardiogram was done pretty shortly after he got to the unit, which did show some RV dilation, increased pressure, but his coronary arteries looked okay. He received some IVIG and pulse steroids when he got there. So when we get a patient either from the ED or the floor who's been febrile and tachycardic, we try to work through, why is this patient tachycardic? Is it purely because the patient has a fever? Do they have a lot of inflammation? Or is this patient indeed in compensated shock? And we look at the patient, looking at their mental status, looking at their perfusion, looking at their blood pressure, just kind of an overall gestalt, as well as their urine output. So this is a graph of our patient in the first 30 hours of his PICU stay. And on the graph, we are looking at our markers of oxygen delivery. So in the red, his lactic acid, in the blue is his mixed venous sats, and in the gray are the NIRS that we're looking on. So the first, if you could go back one. You can see when he got to the PICU for the first day, kind of over in this area here, for the first part of the day, he remained tachycardic but pretty stable. Got his IVIG middle of the afternoon, and then got his pulse steroids a little bit after that. And then right around here during shift change, you can see that things changed a little bit. He got a little bit more tachycardic, and you can see his markers of oxygen delivery change. So looked like perfusion went down, lactate went up, resuscitation started here, got some fluid boluses, and you can see that his lactate got up as high as 8, and then by the morning after resuscitation, his lactate was down to 2.6 with his other oxygen delivery looking pretty good. And as we'll see, this lactic acid of 2.6 kind of hovers around with these patients for a couple of days before completely clearing. You can advance to the next stage. Next slide. So on this second day, we did consult cardiology because of the echocardiogram findings and his history. And on review of tele, they noted that he had a 6-beat run of VTAC, but looked like that corresponded with PIC placement. He did continue to be febrile and had increased inflammation. His epi and milrinone that had been started overnight continued. His lactate hovered around 2 to 3, and he started having this marked abdominal distension, and so was made NPO, was started on some TPN and lipids. Continued to have his urine output remain low. However, his kidney function looked all right with his creatinine staying about 0.6. His liver function was getting a little bit worse, and rheumatology then added Anakinra. On day number 3, he looked about the same from a hemodynamic standpoint. He was afebrile on that day. His Anakinra, I believe, was increased at that time. By the end of the day, his tachycardia was starting to resolve. For the first time, he had been in the 130s these couple of days, and then he went to the 1-teens. He was noted to be 6 liters positive and now requiring an oxygen requirement with nasal cannula. And so Lasix was started, and some of his other labs were coming back. We did start some aspirin that day as platelets then finally came up above our threshold, which at the time was 100. On day 4, he also started the day out on his vasoactives, and cardiology noted that he had a 6-second run of SVT in the morning. It looked like his oxygen delivery was getting a little bit better. His epinephrine was able to be discontinued, and we continued with diuresis, and everything looked like it was getting better, although he did spike a fever and cultures were drawn. The next day, his culture did result with some staph, so antibiotics were added. And looks like around day 5, things were really getting better, and his lactate finally normalized. We were able to come off the milrinone and advance his diet. And then on the next day, we were able to transfer him to the floor, where he stayed for an additional 3 days and then followed up with rheumatology and cardiology. So last month in the Journal of Circulation, they had a lot of really great articles about the cardiac involvement in MIS-C. And this in particular is a really great review article looking at everything that's been published so far that we know about this disease. And so the question was, for the cardiovascular involvement, is it the virus that directly invades the cardiomyocyte? Is it this inflammatory response that's causing the cardiac involvement? Is it the endothelial injury, hypercoagulability, and microvascular injury causing the problems? And as a result, we can see ventricular dysfunction, we can see coronary artery involvement, and we can see arrhythmias. And interestingly, last December, this was published. This was a center in France that gets, as a routine, gets cardiac MRIs on all of their patients that get admitted to the PICU who have myocarditis. And so since they were already doing this, they were able to look at this case series of 4 patients with MRI and look and see what their heart looks like. And what they saw was that all of these patients had diffuse edema, but they didn't have any evidence of fibrosis or necrosis, which really favors more of myocarditis post-infectious, like we see in Kawasaki disease, comparing post-mortem cases of Kawasaki diseases, the same kind of edema, but no necrosis. So this is a graph, that review article, this is all of the articles that they included in this review. And over on the left-hand side, you can see the percentage, all of the bars represent each of the different studies. And this is the percentage of patients that had LV dysfunction, and over on the right, the percentage of patients that had coronary artery involvement. And this is a graph from a study done with CDC data back in July in the New England Journal of Medicine, which just shows all of the cardiovascular involvement. And this mirrors what all of the studies that have been published. And about 80% of the patients do have cardiovascular involvement. About 91% of the patients do have echocardiograms. And you can see that a large percentage of them, about half of them required vasoactive support. They had elevated troponins and BNPs. Some of them did have pericarditis or effusions. A small number of them were very sick with EFs of less than 30% and 4% of them requiring ECMO. Okay, so the takeaway from this review is that a majority of these cases were in previously healthy children. The most common comorbidities are asthma and obesity. And once again, minority populations are overrepresentative. Acute myocardial dysfunction is the most common cardiac manifestation with mild dysfunction, and as you can imagine, the patients that were in shock were at highest risk. There was one study that showed that elevation of troponin and BNP was very common, and it was associated with shock and LV dysfunction. And one of the things that we're going to be looking at with our multi-center study, one of our fellows, Dr. Zaffarani, is going to be looking at the BNP to see if there's a particular level that would predict need for vasoactive support and therefore ICU admission. So in the high acuity cohorts, there was 2 studies, one of them 35 patients, where their inclusion criteria was LV depression. And these patients were pretty sick with about one-third of them having severe dysfunction. 80% of them required inotropic support in contrast to the 50% in the general population, and 28% required ECMO. Most of them had recovery of their LV function, and it happened pretty quickly within a couple of days. And in the second study was a little bit smaller study where most of them did require inotropic support and no ECMO, and in both studies we had no deaths. We can definitely see coronary artery involvement, as mentioned, but very few aneurysms, and most of them are small and with just a few large. But the really important thing is that we have seen that some of these aneurysms can develop in the convalescent period, so after they've been discharged for the hospital, so important to have close follow-up. And etiology of these, just inflammation and disruption of the arterial wall. We can also see arrhythmias. We can see a variety of them reported, and we've also seen those here in our patients. And in the ICU, again, to support oxygen delivery and organ function, we have a multidisciplinary approach, and we use fluids, inotropes. We can use mechanical ventilation, and if needed, in a small percentage of them who are really sick, we do support them with ECMO. Now Dr. Eid is going to talk about treatment.
All right, thanks, Michelle. Okay, so if you can go to the next part of this slide. Yeah. So ideally, obviously, treatment for any disease should be based on randomized, double-blind, placebo-controlled trials and large meta-analysis studies. But unfortunately, this disease is only 11 months old. There's only been 2,000 reported cases here in the US, so we don't have any of that to guide our decisions. So we're left with really bad information on how to make decisions. Case reports, small case series, consensus-based recommendations, and personal experience. So the goal with treatment for these patients is to stabilize the life-threatening manifestations and to prevent long-term sequelae of the disease, and that's primarily manifested in the cardiac manifestations that Michelle just discussed. So the bulk of these recommendations are going to be based on that article from Arthritis and Rheumatology that Wasim had spoken about earlier. And this, again, was a consensus-based recommendations that were made. It was a task force of 16 different physicians, including 9 pediatric rheumatologists, 2 adult rheumatologists, 2 pediatric infectious disease specialists, 2 pediatric cardiologists, and 1 critical care pediatric specialist. So again, these are recommendations that are not based on hard data. And I can't stress this first point enough. Just like Michelle was discussing, supportive therapy is really the cornerstone of what makes patients with MIS-C get better. If you don't adequately oxygenate, adequately support their hypotension, they will not do well. The other recommendations definitely help, but supportive therapy is the key. In terms of antiplatelet and anticoagulation therapy, low-dose aspirin has been recommended with a max dose of 81 milligrams in all patients if their platelet count is 80,000 or above at this point. If they have significant bleeding risks or they're actively bleeding, you shouldn't use aspirin, obviously. You usually should use it, it's recommended to use it for until the 4-week echocardiogram is negative and no signs of coronary arteries, and the platelet count returns to normal if it was elevated. And then in terms of anticoagulation, it's generally not recommended for patients with MIS-C in general, unless they have significant coronary aneurysms, so Z-score of greater than 10, or if they had a documented clot, or if they have significant cardiac dysfunction. And then I'm going to go into the immunomodulator therapy in the next slides. So IVIG is a medication that's prepared from a pool of antibodies donated by healthy individuals. And it's used in a variety of different conditions, primarily immunodeficiency syndromes, autoimmune diseases, and inflammatory diseases, including Kawasaki disease. And as we've been discussing, this disease was often mistaken for Kawasaki disease early on. That's why it was used initially. The mechanism of action is poorly understood. There's a lot of different theories behind why it works, but generally it's anti-inflammatory. The dose recommended for IVIG is the same in MIS-C as it is for Kawasaki disease. A high dose of 2 grams per kilogram ideal body weight. You should consider splitting the dose if the patient has severe cardiac dysfunction. And as opposed to Kawasaki disease, at this point, we're not recommending giving a second dose of IVIG just because there's not a lot of data that it would be useful. Next slide. So everybody knows about steroids. It's one of the most potent anti-inflammatory and immunosuppressive agents that we have. It's used in a plethora of different inflammatory and autoimmune diseases, including Kawasaki disease. And generally, low to moderate dose is recommended as an adjunctive therapy for IVIG in patients who present with shock, organ-threatening disease, or other concerning features. Some centers are using it in all patients that present. And then IV pulse dosing, which is kind of maximum dosing of corticosteroids, is used in a dose of around 30 milligrams per kilogram of a max of 1 gram per day. Usually we use it around 3 days, up to 5 days have been used as well. And this is generally used in patients who don't respond to the combination of IVIG and low to moderate dosing of steroids, or in patients who are multiple inotropes or doing very poorly right at the onset of the disease. Generally, we're recommending using methylprednisolone or solumedrol as the corticosteroid agent of choice. There's been a recent study at the beginning of this month from France that showed that the combination of IVIG and steroids lessened the duration of fever and a couple of other secondary endpoints, including ICU stay, compared to IVIG alone. This is from a JAMA article. It was from the National Public Health Agency in France. There were small numbers. It was a retrospective review, and the dosing of the methylprednisolone in this study was kind of all over the place. So you can't really say at this point that that there's good evidence that steroids is the answer here, but certainly there's some evidence out there, and generally it should be recommended to use steroids in these patients. Next slide. So Anakinra is a recombinant human interleukin-1 receptor antagonist. It's FDA approved to treat rheumatoid arthritis and a rare periodic fever syndrome called neonatal onset multisystem inflammatory disease. We've been using it for about the last 20 years in pediatric rheumatology, off-label to treat systemic juvenile idiopathic arthritis, as well as other rare inflammatory diseases. It's currently being studied in Kawasaki disease, primarily in patients who present early on with coronary artery aneurysms. It's an attractive medication because it's got a very short half-life. The median is about 5 hours or so, almost 6 hours. And so, again, these patients often present looking almost identical to someone in septic shock. So in the early stages, using medications that will stick around a while can be precarious, because if the patient turns out to actually have sepsis and you're using immunosuppressive drugs, obviously that's not something that's generally recommended. So this drug, having a short half-life, is attractive in that sense. We generally are using high-dose Anakinra, so greater than 4 milligrams per kilogram per day. The drug it comes as a subcutaneous injection, but it can be formulated into an intravenous solution. That's generally what we've been using here in the hospital. And it should be considered for patients who are refractory to IVIG and steroids. If they have features of macrophage activation syndrome or hemophagocytic lymphohistiocytosis, which would include hyperferritinemia and transaminitis and pancytopenia and DIC. And if you have a contraindication to long-term steroids, then this would also be considered a good treatment option. Next slide. So other immunomodulatory therapies have been only used in kind of very small case series, or generally used third or fourth line. And these include anti-interleukin-6 agents such as tocilizumab, which has gotten a lot of press in the adult world for acute COVID and hyperinflammation related to acute COVID. Anti-TNF agents such as infliximab, and the Janus kinase inhibitors such as tofacitinib and baricitinib and upadacitinib have been used as well. Again, these drugs generally have longer half-lives, and they are immunosuppressive, so you have to use caution with them. Next slide. In terms of the outcome, as Wasim mentioned earlier, there's been 30 deaths reported in the CDC website, and so that's about 1% of the 2,000 total cases that have been reported. So mortality with this is generally low. And in terms of other symptoms coming back after the acute phase, that's also very low. There was a small study, and I put some data here showing that there's been some of the symptoms coming back up to 2 weeks after the initial phase, but generally the major outcomes of concern are coronary aneurysms, arrhythmias, and myocardial dysfunction. So that brings us to how we should follow up these patients. Generally, from a rheumatology standpoint, we're recommending that they follow up with us in our clinic between 1 and 4 weeks after discharge. And really, they can be referred to any of our 4 providers here at Phoenix Children's. At that visit, we usually check labs again, the basic labs, including inflammatory labs, and some of the cardiac markers, as well as a ferritin level. Again, we continue low-dose aspirin until the platelets are normal and there's been a confirmed normal echocardiogram 4 weeks after the diagnosis. We generally are treating with steroids for a course of about 14 to 21 days, depending on their clinical course during their hospitalization. And we discuss other general recommendations, including live virus vaccine delay after receiving IVIG in the hospital, not going back to physical education or competitive sports until they're cleared by cardiology. And so follow-up can be arranged with us by calling our clinic number there. Next slide. In terms of cardiology follow-up, there is a new clinic here at Phoenix Children's that is focused on MISC patients as well as Kawasaki patients and patients with coronary disease, called the Comprehensive Coronary Clinic, that's headed by Drs. Nowlin and Dr. Sabati of the cardiology division here. And patients with MISC should be seen at 2 and 6 weeks after discharge and beyond. And they perform additional testing, including cardiac MRI, Holter monitors, exercise stress tests around 6 months after the diagnosis. And so you can contact their clinical nurse, Amy Johnson, at the phone number listed there, or contact the inpatient cardiology service if the patient's admitted here at Phoenix Children's to arrange the follow-up. So we are doing some research here at Phoenix Children's on patients with MISC. It's called the MISC Phenotype Initiative. It's a collaboration between the CDC, Emory, Washington University in St. Louis, Orlando Health, and us. And the aims of this study is to characterize the phenotype of patients with MISC and compare it to other similar diseases such as Kawasaki disease, toxic shock syndrome, and acute COVID. And the secondary goal is to evaluate the utility of the antibody testing in differentiating between MISC patients and patients with acute COVID. And our principal investigator here is Dr. Rosenberg. And so just to kind of summarize, MISC is an evolving disease. It's linked temporally to infection with SARS-CoV-2. We're using the CDC case definition to diagnose patients here. Clinical presentation and the pathogenesis is similar but not the same as patients who have Kawasaki disease. Diagnosis at our institution is aided by this 2-tiered lab approach and involving the appropriate consultants. And our treatment is aimed at stabilizing patients and preventing long-term outcomes, long-term sequelae. And at this point, the outcomes are really unclear, and patients are going to require outpatient-specific follow-up. And so just to finish up, it really takes a village to take care of complicated patients like this. So we wanted to thank the members of the infectious disease division here, the members of the rheumatology division, the members of the critical care division, the comprehensive coronary clinic, and the members of the division of cardiology here, as well as the Phoenix Children's hospital medicine group, because it really takes all of us to make sure patients are having good outcomes here. We also wanted to thank our study group here, Dr. Rosenberg, Dr. Zaffarani, nurse practitioner Ippolito, from pharmacy from the lab Matt Pankratz, and our research coordinator Rosio Ortega. And finally, we wanted to thank our Chief Medical Informatics Officer, Dr. Vinay Vidya, who helped create our MISC dashboard. And with that, we'd be happy to take any questions. Thanks so much.
All right, thanks everyone. And it looks like we have a few questions through the Q&A section. So the first one is, asking about the differentiation between Rocky Mountain Spotted Fever and MISC. Obviously, there's a lot of overlap. Some of those kids, present sick, in the same way. And, what I would say about this is the approach to managing patients coming in shock, needing ICU care, should be a multidisciplinary approach. And definitely, if there's that concern, whether based on the epidemiology, for example, if the patient is presenting during the right time of the year from the locations where we know that Rocky Mountain Spotted Fever is very prevalent, then it is appropriate to treat for both potentially. And a lot of times there's going to have to be a clinical decision whether you go ahead and give the immunosuppressive medications or give the immunomodulators like IVIG along with doxycycline if there's that concern, while you're trying to kind of gather more data and see if it's going to be RMSF or MISC. Same thing actually applies. We've had a couple of kids who presented and were initially suspecting MISC. Obviously, they were in shock. We had them on antibiotics, and eventually we grew Staph aureus from their blood. So yes, the presentation of shock, that sometimes can kind of confuse you, and there's that question, and you might need to cover for both or multiple possibilities at the beginning as you're trying to sort out these situations. Question is about if the tier 1 labs are concerning, should the rest of the evaluation tier 2 labs be done as an outpatient or in the ED? MISC management is an inpatient management. So if there's a concern from the tier 1 labs that there's an inflammatory process going on, we definitely recommend not waiting and send the tier 2 labs as an outpatient, send those patients to the ED, because if the tier 2 labs are more concerning that this is MISC, they will need to be admitted. Next question is there a collaborative effort here in Phoenix with Banner to create uniform protocol? So the answer to this is actually the infectious diseases physicians go to the Banner hospitals, and we're using the protocol that we developed here at PCH. So because we're kind of guiding that management. So there's no official collaborative, but the management is guided by the infectious diseases physicians at the hospitals that don't have the rheumatology division or, their critical care physicians are not very familiar with this. Is there any experience with the report from Israel on the use of inhaled EXO-CD24? No, there's no. What is your ECMO experience? Yes, we've had patients who went on ECMO. Some of them recovered, but obviously this is the extreme of critical support. And I don't know if Dr. Munkwitz wants to make a comment about the patients that we've had who needed ECMO. You're muted. Yep.
Sure. So from my recollection, we've had 3, and at least a couple of them were a little bit complicated. In all 3 of them, we didn't know that it was MISC, meaning we didn't have epidemiologic link until the lab, the IgG came back. One of them was complicated by coming in with heat stroke, and then the IgG came back positive later. I believe he was treated, and he actually died, we believe, from his heat stroke. And another one was someone that we thought probably had a meningitis, septic shock, and was really a very mixed picture as well. And the other one also was a mixed picture and looked more like a toxic shock in the beginning, and didn't know until later the next day that she actually had IgG positive.
There's a question that might not be too related, but my favorite topic is about the vaccine, the COVID-19 vaccine. And the question is about, the complications of the vaccine. Obviously this is not the forum to talk about this, but what I just want to remind people is that there's now more than 42 million doses of the vaccine that have been given. And if you follow the news, obviously, we haven't seen the reports of, the scares related to that. What I would say is that there was some concerns initially that how would the COVID-19 vaccine, when it starts rolling into the pediatric population, would that trigger an MISC reaction? That's obviously still to be learned with the studies that are being done. But what we know is that in adults, there is a presentation, that they're now calling MISA, which is basically MIS, but in someone who's older than 21. So that in hyperinflammatory presentation is seen in adults with COVID-19. And now after the vaccine, there hasn't been any link in adults that have went into this. So, obviously it's not as common in adults compared to the pediatric population, but that kind of gives us an idea that, it sounds like it's going to be unlikely that the vaccine would trigger that reaction. The next question is, for patients with multi-organ dysfunction from MIS-C versus sepsis, is Anakinra something that can be used sooner if there's a hesitation to use glucocorticoids? Kaleo, do you want to answer this?
Yeah, I think that's a good question. Unfortunately, there's no data to support that Anakinra should be used earlier. The recommendation from the American College of Rheumatology is to use steroids first. So that's kind of what we're doing. Hopefully, we get some studies to help guide. I think the logic behind considering Anakinra makes sense earlier because of the short half-life, but at this point we're not really sure yet.
Next question is a great question also. It's about the role of the primary care pediatrician in follow-up of these patients, and how can the primary care pediatrician best support the patient. That's a great question. Obviously, we're still learning about how to follow up those patients, and I don't know, Kaleo, if you want to speak to this since
Yeah, I think the primary care physician can definitely aid in the follow-up by seeing the patient sooner than anybody else. I think generally we're recommending when the patient's getting out of the hospital to be seen by their primary care physician within the first 1 to 2 days after hospitalization. Because if they are going to get a fever that comes back, it's going to be pretty soon after. So just seeing them clinically, getting their vital signs. I don't think you necessarily need to send any labs at that point, but making sure that they're on the right track, whether it's a telehealth visit, a Zoom visit, or in person, I think is really important and can help raise any red flags for recurrence of the disease early on.
I mean, that's very interesting. We're having a lot of questions, so I'm going to have to be selective, and I'm going to try to do like a quick run through the different questions. There was a question about the ECMO experience, and Dr. Munkwitz already touched on this. The question about the viral etiology for Kawasaki disease in relation to MIS-C, we've always speculated that that's, the case, but the specific virus is still to be determined. There's, some research now on a lentivirus that actually potentially could be the trigger for Kawasaki disease. But again, the immunology seems to be through a different mechanism. Plasma treatment and antibody treatment. Well, the antibody treatment is what we're giving the IVIG, but I'm not sure if that means if the antibody treatment is triggering MIS-C. We're not aware of this. Appendicitis seen with MIS-C, absolutely, because again, it's a serositis type of presentation or GI involvement. So we are seeing patients who are needing appendectomies with MIS-C. There's a question about the other diagnoses that could have presented like MIS-C. So we talked about Staph aureus toxic shock syndrome. Staph aureus toxic shock syndrome. There's also Staph aureus sepsis. Any kind of presentation of sepsis could potentially, kind of manifest as a possible MIS-C. Aplastic anemia. Well, I'm not sure what exactly the question related to aplastic anemia. And is the exposure within 4 weeks criteria relevant when the rate of community spread has been so high? That's a great question, and actually I did mention this, briefly. So the exposure to be documented is simply to keep the CDC data kind of clean and accurate. But as we said, we are sometimes having to manage patients for MIS-C even when they did not fulfill the epidemiologic link, because the expectation is that if there's a widespread virus in the community, they've probably had an exposure that they were not aware that was an exposure for someone who had acute COVID-19. Remember that some of the patients who have acute COVID-19 are asymptomatic or mildly symptomatic. So, they can potentially expose someone else without knowing it. And I think all the questions we can take. I'm sorry, we're running out of time, but great discussion. Thank you.
All right, good.
Thank you guys so much for joining us today. That was a tremendous presentation and tremendous audience and questions as well. Have a great day, everybody.
Bye.